My disclosures again, and our objectives: understand the basics of coagulation, available anticoagulations, their indications and use with respect to VTE, understand VTE management in the era of DOACs, direct oral anticoagulants, and discuss reversal strategies for patients on direct oral anticoagulants. We'll start off with a page that I got. This is, I think, a little over a year ago. This is a 45-year-old man with acute pancreatitis, alcoholic pancreatitis, complicated by a portal vein thrombosis who has been started on a heparin drip. And the team is asking for a heme consult, whether he could be switched to a DOAC, and if 3 months would be the appropriate duration of treatment. That's the page. I want you to think about it, and I want you to ponder on the issues here. Pancreatitis, heavy chronic alcohol use, unusual site of thrombosis, has necrotizing pancreatitis, which is a potent prothrombotic risk factor. His coags are normal. His PTT is 29 seconds. And how should we treat his VT? And we'll try to address the answer here. Observation, because it's incidental and asymptomatic, should we put him on unfractionated heparin to warfarin, unfractionated heparin to dabigatran, unfractionated heparin to an anti-10A, or none of the above? What do you think is the best answer? We'll talk about the best answer at the end of the talk. So, DOAC versus NOAC. We don't use the term NOAC anymore because in numerous occasions it has been confused for no anticoagulation, and bad stuff has happened. So please change your practice pattern and say DOAC rather than NOAC. This is how various anticoagulants work. This is a summary slide for the mechanism of action. And of course, we're dealing with the coagulation pathway here. If you're not a hematologist, you're probably not in love with this figure of the intrinsic versus the extrinsic pathway and where and how both of them interact. But unfractionated heparin works via antithrombin 3 on several parts of that pathway. Low molecular weight heparin, on the other hand, works mainly on factor 2 and factor 10, also predominantly through antithrombin, but also by other mechanisms. The direct acting anticoagulants, so 10A inhibitors, Rivaroxaban, Apixaban, and Edoxaban, all work on 10/10A, whereas the direct thrombin inhibitor, and right now we have only one thrombin inhibitor, dabigatran, that is oral. We do have intravenous drugs like bivalirudin and argatroban that are also direct thrombin inhibitors. So, they all work on different parts of the pathway, and what's complicated is how to assess, how to monitor these labs, how to monitor efficacy. It gets very confusing when you have so many different drugs with several different mechanisms of action. As we discussed before, anticoagulation for VTE really falls into 3 phases. The acute phase, that is about the first week of therapy, the chronic phase, which is after 3 to 6 months, and everything else that is in between. And these are the various drugs that can be used in each of those phases. Please notice dabigatran and edoxaban are not used in the acute phase. Why? Because the trials that got these drugs approved did not use these drugs in the initial first week period. They started using the drug after patients were on drugs like unfractionated heparin or low molecular weight heparin in that initial part. So if you're taking your boards and you get a question about VTE treatment in the first week of therapy, dabigatran and edoxaban are never the right answer, okay? It's not that those drugs won't work, it's just that the studies were done without these drugs being started off at the diagnosis of VTE. They were started a few days later. So, but apixaban, rivaroxaban, you can start it immediately. This is a great summary slide for all the DOACs, so please pay attention to this slide or take a mental picture. So if you look at the dosing strategies for the various DOACs, and I'm not going to spend too much time on warfarin because I assume that most of us would know enough about warfarin, its long half-life, how to monitor it with PT/INR and its potential interactions. But let's focus on the DOAC. So first we'll work with dabigatran. It's a thrombin inhibitor. It's the only oral thrombin inhibitor. Twice a day dosing, a half-life of about 14 to 17 hours, highly renally cleared. Okay, we generally avoid dabigatran in patients with renal disease. It's extremely highly renally cleared of all the drugs we're assessing here. And there is no test to monitor efficacy. There is a test to monitor presence of drug, but you can't titrate it to monitor efficacy. And then we have the three 10A inhibitors, Rivaroxaban, Apixaban, and Edoxaban. I think Rivaroxaban and Apixaban are probably number 1 and 2, and you may be able to switch those for market share right now for the direct oral anticoagulants for VTE. They're 10A inhibitors. The unique thing about Rivaroxaban is look at its half-life. The half-life for Rivaroxaban is actually lower than the half-life for Apixaban, but yet it's a once-a-day drug. Why? Because that's how the company chose to market the drug and to design the trials. Okay, it doesn't make a lot of sense, but that it is how it is. Rivaroxaban is started off at 15 milligrams BID dose for the first 3 weeks and then switched to once daily dosing. So that's the reason for that higher intensity anticoagulation for 3 weeks in the setting of acute VTE, because this drug actually has a very short half-life, but then it goes to once a day. Apixaban, on the other hand, is higher dose, 10 BID for the first week, and then goes to 5 BID continuously. So there is a disadvantage for Apixaban in being a BID drug and your patient having to take it twice a day. But the half-life is actually shorter for Rivaroxaban than it is for Apixaban. Apixaban is the least renally cleared of all these drugs. And if you were asked hematologists which drug they're most comfortable with in someone with renal disease, it's probably Apixaban. Apixaban is approved for AFib in the setting of chronic renal disease. It is not approved for VTE in the setting of renal disease, but it is probably the most used DOAC in renal disease purely because of its lowest renal clearance compared to everything else. Okay, I get asked this question a lot, which is the best drug for VTE treatment? And this is a summary slide of VTE trials. Notice on the right, what's the comparator? Warfarin. And on the left are all 4 DOACs. And can you tell me, based on that slide, which is the best drug? Is anything better than Warfarin? These are all non-inferiority trials, okay? So when I get asked this question, which is the best drug, there is no best drug. You make choices based on what you think may be better for that patient in that unique circumstance or situation clinically, but it's not like any of these drugs have been shown to be better than Warfarin, okay, for prevention of thrombosis, for recurrent VTE risk. So I want you to understand that they have about the same efficacy. So if somebody is blowing through, clotting through Rivaroxaban, just changing them to another drug is probably not going to actually change the overall outcome. Bleeding risk, again, all of these are, on the left are DOACs, on the right is Warfarin. So some of them do a better job at prevention of bleeding on anticoagulation than others. Apixaban is thought to have generally the lowest bleeding risk compared to all the others. And that's one of the reasons that for VTE treatment, DOACs, especially Apixaban, is considered a primary choice just because of bleeding risk. So factors to consider when making anticoagulation decisions: consider the bleeding risk, and especially in older patients who may have vascular disease. DOACs have similar efficacy, reduced need for monitoring, and a better bleeding risk profile in some situations compared to Warfarin. And lastly, in patients who have a history of HIT, heparin-induced thrombocytopenia, fondaparinux is a subcutaneous 10A inhibitor that has the longest data, but now we're also seeing oral 10A inhibitors, Rivaroxaban and Apixaban, newer data coming out suggesting efficacy in HIT, although not FDA approved for treatment of HIT. Okay, so again, I get asked this question a lot. What's your guidance in advising patients in consideration of chronic anticoagulation? Warfarin or DOAC, and if the latter, which one? And this is my my summary slide that, I don't know, you can put several hours of hematology consult into this one slide. So if somebody has extensive clot where I think they might need thrombolysis, or they're hospitalized and they may need procedures, unfractionated heparin is easy to turn off. That's what I use. Someone who is high bleeding risk who's hospitalized, I use unfractionated heparin. Active malignancy, and I'll show you some of the cancer data later on. I use either low molecular weight heparin or a 10A inhibitor, Rivaroxaban or Apixaban or Edoxaban. Pregnant patients, I'm a strong believer in low molecular weight heparin. The anesthesiologists taking care of the patient who is about to deliver don't necessarily agree with hematologists all the time. In about 50% of cases, I'm able to convince the anesthesiologist that we don't need to switch the patient to unfractionated heparin for the actual delivery. But in 50% of the times, I'm unsuccessful and they demand a switch to unfractionated heparin. But I like low molecular weight heparin for pregnant patients. None of the other drugs should be used in pregnancy. Warfarin can be used late in pregnancy, not with breastfeeding, but I just prefer keeping the patients on low molecular weight heparin throughout. It's just so much easier. Liver dysfunction with clot is a tricky area. Do not use DOACs in patients with Child-Pugh B or C liver dysfunction. It is asking for trouble. I stick with either warfarin, which you can monitor, or low molecular weight heparin. In patients with major mobility problems where they're not able to show up to get their INR monitored, I would rather have them be therapeutic on a DOAC rather than not know what their INRs are on warfarin, unless of course you can get them a home monitor. Drug cost, warfarin is much, much cheaper than any of the DOACs. Morbid obesity, and the official number is 120 kilograms. So none of the trials assess anticoagulation efficacy in patients who are over 120 kilos. So remember that you're using the same dose of DOAC for somebody who's 50 kilograms versus somebody who's 115 kilograms. There's got to be some difference there, right? So once you get over that 120 mark, I'm not comfortable using any DOAC. Renal disease, Apixaban is something that I'm comfortable with, especially long-term, or warfarin. And for extended treatment, there's very good data. I showed you low-dose Apixaban. The efficacy is excellent, 80% risk reduction, and the bleeding rates are as good or as bad as placebo. So that's my drug of choice, low-dose DOAC for extended anticoagulation. And lastly, convenience. Both Rivaroxaban and Edoxaban are once daily drugs versus Apixaban being twice a day, and dabigatran being twice a day. Okay, we're going to go to our next case. This is a 24-year-old man without chronic medical illnesses who comes to the ED with 3 days of dyspnea and chest pain. His pulse rate, respiratory rate, and SATs on room air are relatively normal, so maybe slightly tachypnic. Blood pressure is normal, a D-dimer is elevated, and a CT angio confirms a right-sided segmental pulmonary embolism. He has good social support and insurance coverage for either low molecular weight heparin or DOACs. Which strategy is both efficacious and cost-effective? So you could admit the patient for unfractionated heparin because he has a PE. Start Rivaroxaban 15 BID and discharge. Start Edoxaban and discharge. Admit for inpatient low molecular weight heparin. And lastly, start dabigatran and discharge. What do we think we should do? This is a little bit of a complicated question. You have to think of multiple things here before making this this choice. Actually, that's really good. We have we're bang on target there because remember we talked about Rivaroxaban being a drug that you can start when the VT occurs, but you cannot do that with dabigatran or Edoxaban. So thank you for not choosing those two. It means you guys are listening to me. But Rivaroxaban 15 BID and discharge is probably the best choice. This is a young man with good social support. It's unlikely to have bad outcomes if you don't hospitalize him. So outpatient management is probably preferred to inpatient management. You don't have to admit everyone with a PE. You can just start them on Rivaroxaban and discharge if they are clinically stable. Obviously, clinical instability, you need to admit the patient. All right, next we'll go to DOAC reversal. what do you do when a patient is bleeding on a direct oral anticoagulant? Firstly, can you detect it? How good are your tests and what is their turnaround time? This is very, very crucial. If you had a great coagulation test that could assess presence of drug, therapeutic range of drug, like you have for warfarin, right? You can get an INR back in 30 minutes from the emergency room and you know what their levels are. You don't have those kinds of, you don't have that, that luxury for the 10A inhibitor. So what do we do in these situations? So I'll go through the DOACs and the intricacies of each of these tests. So for dabigatran, since it's a thrombin inhibitor, the thrombin time is extremely sensitive, but PTT is a reasonable, not so accurate alternative if the thrombin time is not available. Okay, so again, for dabigatran, thrombin time or PTT. For 10A inhibitors, on the other hand, you have to use a 10A assay, an anti-10A assay. The PT, the prothrombin time, is a reasonable but not so accurate alternative that is used instead. But a 10A assay is the much better test. So the problem with PT and PTT for dabigatran and 10A inhibitors, 10A inhibitors and dabigatran respectively, is if you see a normal PT in a patient on Rivaroxaban, it does not exclude therapeutic levels. Okay, it is just not a great test. So if you want to have a reasonable assessment of efficacy or presence of drug, you really need that 10A level for Rivaroxaban or apixaban, and you really need that thrombin time to assess presence of drug for dabigatran. So again, there's a lot of data on this slide, but I would just want you to kind of take home these few points of thrombin time versus PT versus PTT versus 10A levels for each of these drugs. The anti-10A assay, I'm sure most of your hospitals' practices will have access to an anti-10A assay that is calibrated to either unfractionated heparin or low molecular weight heparin. This is a test that has a faster turnaround time than a 10A assay that is calibrated for a DOAC. So you have to adjust it for which drug you're testing it for, and that technology is not widely available. So if you have a patient who's on Rivaroxaban or apixaban and they show up bleeding, how do you assess if there is active drug within their body or not? You use a unfractionated heparin 10A assay, which can give you an estimate if there is some drug in the body, but cannot give you a good idea of how much there is. Okay? All it does is tell you, okay, there's drug, but it doesn't give you good quantification because it's calibrated to a different drug. But the advantage is a faster turnaround time. Okay, so what happens? So that's dealing with the coagulation tests for the various drugs. Again, complicated, and that's why you have the slides, you can always refer to them. Okay, so what happens when somebody comes in with life-threatening bleeding on these drugs? They've bled into their head or they're perforated their heart and they need to be urgently reversed. What do you do then? It depends on which drug you're on. If you're on warfarin, obviously you have to give them IV vitamin K, but we prefer a product called PCCs, which are prothrombin complex concentrates that only have 2, 7, 9, and 10. All the other factors have mostly been removed. So we prefer PCCs to fresh frozen plasma, to FFP, for treating warfarin-caused life-threatening bleeds. If you bleed on dabigatran, there's a highly specific antidote called idarucizumab, and if you bleed on factor 10A inhibitors, we used to use this drug called FIBA, which is an activated prothrombin complex concentrate, until recently when this other drug, andexanet, got approved specific for 10A inhibitor. So it's very important to know which drug you're on before you can reverse anticoagulation. Okay? So for dabigatran, the reversal agent is idarucizumab. It's an IV infusion. There's very specific dosing guidelines. Most hospitals are actually pretty good about keeping this drug. It's not super expensive when it comes to consideration of reversal. It costs about $6,000 or $7,000 for a dose which may really be worth it for saving someone's life. And you use the thrombin time to monitor. There is an escape phenomenon, so it works immediately and it binds directly to dabigatran, gets rid of it, but then you can have some dabigatran leach from the rest of the body's cells into the vascular component over 24 hours. So you have to be careful that the thrombin time doesn't go back up the next day. The 10A agents, Rivaroxaban, Apixaban, for the first 5 years since introduction, we were using activated prothrombin complex concentrate, something called as FIBA. This is something that was developed actually for hemophiliacs with inhibitors, but found to have some activity in reversing anti-10A agents until the FDA approved andexanet for reversing 10A inhibitors. This directly binds to 10A and competes with the drug for anticoagulation and is very, very effective. It immediately reverses the anticoagulant effect of Rivaroxaban or Apixaban. The only problem with this drug is its cost. It costs about $25,000 to $50,000 a dose. So hospital P&T committees are very, very restrictive in its use. In my institution at Hopkins, we allow use of the drug for only if you have a life-threatening head bleed. If you have a GI bleed, we don't allow its use just because it's incredibly expensive. Okay, we'll move on next to cancer-associated VTE. And I'll start off with this statement: enoxaparin is the standard of care for all patients with cancer-associated VTE. Raise your hand if you agree with me. No one agrees with me? Okay, so I will aim to, you guys probably already know about this data, but I will aim to disprove this. So it really depends. It really depends on the type of patient, the type of cancer. Are they metastatic? Are they on chemotherapy or not? And I'll give you some idea about how I come to this conclusion. So this is the CLOT trial published in the New England Journal about 20 years ago, 15 years ago. And the first author, Dr. Lee, comparing dalteparin to Coumadin for prevention of VTE in cancer. Look at those recurrent VTE curves, clearly divergent. 17% recurrent VTE in the Warfarin group versus only 9% in the dalteparin group. So clearly, dalteparin or low molecular weight heparin is better than Warfarin for VTE treatment, right? But same first author, 10 years later, JAMA 2015, tinzaparin, another low molecular weight heparin compared to Warfarin for the treatment of VTE. This time, no significant difference. The recurrent VTE rates, 7% versus 10% in the heparin group versus the Coumadin group. So why did the CATCH trial, the second trial is called the CATCH trial, why did the CATCH trial fail where the CLOT trial won? Right? So not all cancer-associated VTE is the same. Just as Dr. Sorrentino was mentioning earlier, there's really a difference between the type of patient who presents with the VTE. And the reason for the CLOT trial succeeding where the CATCH trial failed in showing a difference between a heparin-based product and a warfarin-based product had to do with patient selection, okay? So fewer patients on the CATCH trial had metastatic disease. So their thrombosis rates were lower in patients who were being treated, let's say, for adjuvant therapy rather than patients who were being treated for metastatic disease. Fewer patients were receiving active anti-cancer, hormonal or chemotherapeutic drugs. So they may have just been surgerized for their cancer. The mortality rates were lower in the CATCH trial, so generally a healthier group of patients. The warfarin TTRs, time in therapeutic range, is something that's used to assess how good you are at keeping your patients anticoagulated on warfarin. They were similar between both the control arms of both the studies, but the recurrence rates were lower in the CATCH trial versus the CLOT trial because the patients had lower risk. So it's all had to do with patient selection. This is the Hokusai VTE cancer study, edoxaban versus dalteparin for adult cancer patients. Randomized trial, low molecular weight heparin, followed by edoxaban. Remember, for edoxaban, you have to do a few days of bridging therapy versus dalteparin from the get-go. And this is what the results look like. The primary endpoint was recurrent VTE plus major bleeding. And you can see that actually edoxaban seemed to do a little bit better than dalteparin when it comes to prevention of VTE, but there were also more bleeds, especially more upper GI bleeds in the edoxaban arm. So we see this a lot. DOACs in patients who are at risk for upper GI bleeding, let's say a patient with esophageal cancer or stomach cancer, very, very, very reluctant to start them on a DOAC. I would much rather prefer a heparin-based strategy, just because the bleed rates are dramatically higher for DOACs compared to heparin-based strategies, okay? But overall, if you looked at the primary endpoint, edoxaban was non-inferior to dalteparin for the composite endpoint of recurrent VTE along with major bleeding. However, higher bleed rates in patients with upper GI malignancies. So, which cancer patients should you not use a DOAC in, right? Based on that study, and subsequent studies have been published for Rivaroxaban and apixaban also. I'm very comfortable using DOACs in cancer patients now. I think that they're about as good as heparin for treatment of cancer-associated VT. But what kind of patients do you avoid using a DOAC in? So number one is anyone with a upper GI malignancy. Esophageal cancer, stomach cancer, I avoid it. Brain mets, just because of the issue with reversal, we're very, very wary of using DOAC. Drug interactions, be careful. Assess for drug interactions before you start them. Anytime there's compliance problems, there's no way to monitor a DOAC really. You can now start sending off anti-10A tests that are calibrated to a DOAC, but it takes several days to come back. Extremes of weight, remember, once you go over 120 kilograms, these drugs, the DOACs, you really don't have good guidance on dosing. And lastly, liver dysfunction, child spew class B or C, please avoid the DOAC. Drug cost matters. This is a listing of drug prices. Enoxaparin is now generic, but despite being generic, it is a very expensive drug. Okay, it's almost $900 a month. The DOACs are actually cheaper than generic enoxaparin and come to about approximately $400 to $500 a month. And this is not the patient's copay. This is the cost to the system overall is higher for a DOAC than it is for Warfarin, even if you include the visits to the Coumadin clinic once a month. Okay, so we'll go to a case. This is a 71-year-old male with 30-pound weight loss. His counts are normal except a platelet count of 60,000. His CT shows extensive liver and nodal abdominal metastases. An EGD confirms adenocarcinoma of the stomach. His D-dimer is over 35. He's in DIC. His fibrinogen is 147. He has extensive clots in his legs and in his lungs. What is the best strategy? So this is somebody who has cancer-associated VTE from a stomach cancer. Unfractionated heparin, transition to warfarin, unfractionated heparin to low molecular weight heparin, or just go with low molecular weight heparin sub-Q, or do we choose a DOAC or a 10A inhibitor or dabigatran, a direct thrombin inhibitor? We can start polling. So we're doing fabulously there. So you're right, you should avoid a DOAC in patients with upper GI malignancies. And either low molecular weight heparin would be acceptable if you're planning to manage this patient as an outpatient. This guy needed to be admitted to the hospital and put on IV unfractionated heparin with a plan to transition to low molecular weight heparin later. So number 2 and 3 are the most acceptable answers here. All right, our team is paging us back. It's 45 minutes later, and they still don't have an answer. So I'm going to look for an answer from you all. This is our first case that I started off this section with. This is a 44-year-old male with alcoholic pancreatitis who presents with a portal venous clot. He has necrotizing pancreatitis on imaging. He has been started on an unfractionated heparin drip. How should we treat his VTE? Should we put him on observation? Remember, this is a portal venous clot in someone who is a daily drinker and very non-compliant. Should we keep him on observation, unfractionated heparin to warfarin, unfractionated heparin to dabigatran, unfractionated heparin to a 10A oral, or none of the above? We're kind of running short on time, so I'll give you the answer for this one. The answer is actually none of the above, and everyone got it right. Yes, that's great. But the reason for it being none of the above is actually warfarin is a very difficult drug to manage in somebody with who's an alcoholic, who's going to drink every day. And this guy has liver disease, making a DOAC an unacceptable option. So I had to send this guy on Lovenox, on low molecular weight heparin. Although, you know, compliance is probably going to be dismal regardless, but you have to be very careful about liver disease. And you can't not treat portal venous clot, because untreated, that will become chronic and cause even more damage. So you have to treat these patients with something. Okay, and I've explained that a little bit more in this slide. A heparin-based strategy is probably the safest, although compliance is still going to be an issue with an injectable drug. And here you had a clear cause, alcoholic pancreatitis, necrotizing pancreatitis, provoking the clot. But if it's a true unprovoked clot, there are some other unique hematological syndromes that you need to look for, such as MPNs like polycythemia vera, which can cause thrombosis at unusual sites. I think I've come to the end of my slides for the second section, and I would love to take more questions.
We'll open again for questions, and microphones are coming around as well. Let me start with, you have a patient who is on warfarin, but you would like to switch them over to a DOAC. How would you go about stopping one, starting the other?
That's a great question. The easiest answer is to Google it. So there's resources everywhere for how to transition from warfarin to a DOAC. That's the short answer, but basically you stop warfarin. 2 days later, when they're subtherapeutic, you start them on a DOAC. The DOAC onset of action is a few hours. I showed you the half-lives. So, but you basically do start them on a DOAC in 2 days. But this can get pretty complex with the number of drugs that are involved. So I would suggest you just Google it, and there's answers everywhere. We get asked this question a lot, and we have an algorithm at Hopkins for how to transition each DOAC to warfarin or back and forth or to a low molecular weight heparin. But there's resources everywhere to make this easy based on which DOAC you're on and what you're transitioning to.
As a correlate of that, you now have a patient who is on chronic DOAC for his unprovoked VTE, but it's a number of months past, so it's presumably mostly resolved. Now he needs to get his gallbladder out. How